Israel Deaconess Medical Center, a teaching hospital of Harvard Medical School. He's also the Chief Information Officer of the Harvard Medical School, Chairman of the New England Healthcare Exchange Network, and co-chair of the HIT Standards Committee. He's also a full professor at the Harvard Medical School and a practicing emergency physician. Dev is the Executive Director of HealthInfoNet, an independent nonprofit that has at its core mission the operation of Maine's statewide health information exchange. Prior to HealthInfoNet, Dev served as Chief Information Officer of Eastern Maine Healthcare, a 7-hospital integrated delivery network located in eastern and northern Maine. And now I'll just turn it over to Dev and John. Thank you very much.
Well, I'm so happy that Leon could warm up for us, so this is good. I think what you've heard from Leon is the need to especially document policy, procedure, best practice. So here's the challenge Dev and I face. You read Meaningful Use Stage 2 and it says share more data with more people for more purposes, but at the same time complete all privacy and security and compliance requirements. So wait a minute, that's like saying we're going to open the library to check out more books, but the penalty for losing a book gets higher and higher. So how do you deal with these two disparate goals? Well, we'll each give our own perspective. So what Massachusetts said is it all depends on creating a trust fabric. A trust fabric is going to be based on policy. It's going to be based on technology. If we're going to send data to trusted entities, we need to figure out who are those entities. Who are we going to allow into the tent? We're going to have some identity management. We're going to use certificates to identify trusted organizations. We better have pretty strong policies as to, do we allow the Mass General Hospital? Oh, they sound pretty trustworthy. Do we allow Joe's Endoscopy Shack? Maybe not. It's more than just participation agreements and business associate agreements. It's ensuring that policies and processes are in place so that all entities who can exchange data are trusted. So what Massachusetts chose to do is to say this. Based on policy, we will have certain participant organizations. They will sign participation agreements administered by the state government. So that means Executive Office of Health and Human Services and its CIO oversee the entire program of who gets in. Now, once you're in, we hired a company. I have no affiliation with any company. There's no conflict of interest here. I'll just mention it for completeness. Symantec, to issue certificates based on the Symantec route to those individuals who we considered appropriately trustworthy organizations to play in the healthcare information exchange. And then we built some components, not modem or dial-up. It is, in fact, secure gateways that support a couple of different protocols, SOAP protocols and SMTP MIME protocols that allow organizations to share data between organizations. We did not issue certificates to individuals. If you think about it, in the Commonwealth, there are 20,000 doctors and 150,000 or so staff members working in doctors' offices and payer organizations. Issuing certificates and revoking certificates for 150,000 individuals is hard. Instead, we said, well, we could take Blue Cross, Harvard Pilgrim, Mass General, Beth Israel Deaconess, oh yeah, and the 2-doctor practice in Pittsfield, that's a trusted entity, that's okay, and issue certificates to the entity that has individuals within the entity, and by using a series of technologies, deliver a payload to the network border of that organization. Once inside the network, the organization then delivers it into the EHR via secure email, via whatever mechanism the organization sees most appropriate to get to the named individual. So this is what we have, as you can see, is a series of web services. I can look up who is John Halamka and where does he work? Oh, he is a physician at Beth Israel Deaconess. I can retrieve the Beth Israel Deaconess public key. I can wrap a payload in that public key and send it via a gateway to the Beth Israel Deaconess gateway by which it's delivered to the named individual. And there's auditing all along the way with the entire process overseen both legally and technically by the state government and hosted in a third-party cloud that is managed by a hired vendor, but ultimately the state government is the contractual authority. We recognize there is an interesting last-mile problem. I mean, we heard the individual who asked the question about payer-provider transmission. Well, what do I do about connecting these payers that want dial-up modems? Well, although that's an unusual example, I think it's fair to say that not every vendor in use in doctors' offices is completely compliant with all modern health information exchange standards. So we have three approaches by which payloads can be delivered. One, a network appliance. And so our vendor of health information exchange services makes a one-use server box available that is capable of receiving these transmissions and then making them available through a variety of protocols once inside the network. I mean, it could be on a file share, it could be an HL7 TCP/IP transaction, it could be a SOAP transaction, a REST transaction. And so, even though the EHR may not support health information exchange natively, the fact that you've got this middleware appliance between the network, between the backbone and the EHR, allows the mediation, the inclusion of the payload in the EHR. That's one way. Some EHRs will support the modern protocols that allow direct delivery. And then there are EHRs that are just completely incapable of anything. And so fine. You hate to do it, but secure web portals, and that's just the choice of last resort. I mean, we wish we didn't have to do it at all, because I'll tell you, doctors really dislike the idea of breaking their workflow. I'm in the middle of my EHR, oh, I now go to log into a separate web portal to get my health information exchange data. The state government, which oversees the entire process, has got a nice combination of state and federal funds in order to get a variety of tasks done. So what we did for our first year's effort was establish the statewide provider directory, the statewide PKI certificate registry, the gateways, those appliances, and then build some connections to some state government facilities. The next step is to connect further state government functionality so that things like public health submissions of lab and syndromic surveillance are easy. And then we get into a much harder problem. And since this session is a bit about privacy and security, let me just use a completely fictional example. I show up in an emergency department unconscious. You have nothing but my driver's license. You want to deliver safe, quality, efficient care to me. You want to pull data from every place in the Commonwealth that I have consented to release it. I have records, I don't really, it's an example, at McLean Hospital. Those would be my psychiatric inpatient records. I have records at the Fenway Community Health Center for my HIV treatment. I have records at the Betty Ford Clinic for the substance abuse problem, and at Beth Israel Deaconess, I have my flu vaccine. Now, you can imagine my privacy preferences, and everyone has different privacy preferences, might be, you know, I consent to disclose my flu vaccine. Oh, and maybe you can get my medication list. It's exceedingly boring. But I really don't want you to see my Betty Ford Clinic visit because it's not salient to today's treatment. So I have to, in some fashion, opt in to disclose data ahead of time in a statewide registry, so that when I show up in an emergency department unconscious and can't consent, in effect, the clinician gets the data that I have allowed that clinician to see. So what's happening over the next year, and we are just finishing up getting some additional federal funding for this, is a statewide citizen index with attached to it the record locator service. Those medical record numbers you have been known by at healthcare institutions in the Commonwealth, and opt-in consent to disclose, stored centrally, of when those medical record numbers can be released to whom. So in effect, if I, as a technologist, did a web service query on John Halamka, 52362 male, zip code, other demographics, and I would never even get back the McLean medical record number, because the very presence of a McLean medical record number could be disclosing that I had a psychiatric inpatient hospitalization, unless my consent flag was sent to opt in to disclose. So all that is being built over the next year. Number of vendors involved. On October 16th, Deval Patrick, our governor, launched the statewide health information exchange by sending his own medical record from the Mass General Hospital to Baystate, going between two disparate vendor systems, well, one home-built and one a Cerner application at Baystate. And then a series of other transactions followed. To give you an example of those kinds of transactions, and by the way, because this is a privacy conference, I have achieved my wife's consent to tell you this story. My wife was diagnosed with breast cancer in December of 2011, in remission now, doing fine. When she was first diagnosed, she went to a suburban hospital, Newton Wellesley Hospital, fine hospital, and asked for an electronic copy of her record to be sent to Beth Israel Deaconess Medical Center. And Newton Wellesley said, well, at that time, we don't have an information superhighway, we have the Mass Pike. And so we'll print out a paper copy of your electronic record, which you can then drive to the hospital where you'll seek cancer care. On October 16th, the governor pushed my wife's comprehensive electronic health record to Newton Wellesley Hospital, to her payer, Harvard Pilgrim, to a 2-doctor practice running eClinical Works in a suburban community, and to a third-party quality registry who could analyze her data for safe, quality, efficient care, proving that using this trust fabric I've mentioned with certificate management and a directory does enable the transition of payload with patient consent from place to place. And we did a whole lot of other interactions that you can see. PCP to specialist, specialist to PCP, emergency department to PCP, a lot of things that were made possible by the appliances I've mentioned and the web services that I discussed. One interesting barrier to health information exchange in the past, not only policy and technology, but cost. And so what we did for the Commonwealth was we added up every provider in the Commonwealth. We looked at their ability to pay. Chances are Blue Cross or Partners Healthcare can pay more than the 2-doctor practice in Pittsfield. So we actually looked, based on, in effect, their economic wherewithal and the value derived, how much we could charge, and came up with what you see here is a pricing model for full yearly healthcare information exchange capability with all the features and functions I've mentioned. So the biggest organizations pay $27,000, and yes, the little doctor and 2-doctor practice in Pittsfield pays $5 a month. So you could have a subway, or you could have health information exchange and certificate management, your choice. That was a price point they were willing to pay. So we're in the process now over the next couple of months of signing up every provider in the Commonwealth, leveraging about 15 years of experience we have in healthcare information exchange. So I'll just leave you and turn it over to Deb and say what was most important about this whole process is getting all of our stakeholders involved in governance, creating policy which established trust, and then building technology that enforced the policy. And so far, it's working. So Deb, turn it over to you.
Good afternoon. I appreciate the fact that you've hung in there. Obviously, we're the last act, and hopefully we'll be the best act. I always enjoy following John because he brings a certain liveliness to the stage along with a heck of a lot of information. So I'm going to try and paint both some commonalities and differences. I think the fact is that at the end of the day, the concept of trust and trust framework of fabric is the core to how you put together a viable exchange. In my case, it's a statewide exchange, a very different focus, a very different strategy, and some very different facts on the ground relative to the engagement of government versus private sector. But a lot of the themes that I heard from John, you're going to hear from me too. So basically what HealthInfoNet is, it's a not-for-profit corporation in the state of Maine and a 501c3 as far as federal tax position goes. It is a central data repository model, very different from the concepts of a federated model, which is essentially what's rolling out in Massachusetts. This was a conscious decision that was made during a course of a 3-year effort starting in basically 2004 and really terminating and going into 2007, where the advantages of additional objectives beyond just exchange were key in forming the exchange itself. So objectives like being able to do standardized public health reporting. That's a very important objective that was core to the very start of the exchange. The ability to begin to be able to do population analytics, very important as part of the exchange. So this was a decision that was made basically in 2005 and then built upon. So basically today, when we go to a provider organization, whether it's a hospital or a physician practice, we spend the first month and a half or two actually mapping the data that we're going to take into the exchange that's in their systems. So we map everything we can to a standard. So laboratory orders and radiology orders all get mapped to LOINC. Results get mapped to SNOMED CT. And at the end of the day, the only thing we can't map today, believe it or not, is allergies. There just is no standard to work off. What that then allows us to do is be able to look at that data as actionable data across institutions. And that has a very important second story, which I may not get to today, but the ability to start actually working in cross-institution clinical decision support. And as institutions are starting to look at us as the only true community-wide view of the patient moving between institutions, some of that stuff is becoming very important, starting with things like notification. So right now I'm working with a group of care managers across the state, and they assign and associate themselves with those patients and actually are notified when certain actions occur, like walking into an emergency room or being discharged or being admitted, or certain types of results and tests coming into the exchange from somewhere else. Those are all automated notifications. They are within a minute and a half to two of the event occurring. So that's one of the wonderful things about being a near real-time structure. We have entered a very interesting period, and we are an opt-out consent model state. I'll tell you a little bit more about in a minute how that got to that point. But last year, in its infinite wisdom, our legislature decided to change some laws that had been in place for some time around HIV and mental health, and permitted those licensed providers, particularly mental health providers, to begin to release a set of data to the exchange with the understanding that that data would not be accessed unless the patient specifically had it opted in. And so we are now in the process of transitioning to a very confusing opt-out if it's general, opt-in if it's mental health or HIV, and we'll find out where that takes us over this next year as we bring it out. From a technical perspective, clearly, it's been a challenge because now we have to manage what we used to block. Now we have to manage in and sequester and set it up so that we can actually have the patient determine whether or not they want that exposed or if they want to get out. In our state, interestingly enough, and this was the net result of bringing together stakeholders in 2006, we negotiated an opt-out strategy with the understanding, and I don't think anybody else is doing this right now, that if you choose to opt out, we remove your data. So basically, we manage the data back out of the structure and provide you with audit if you wish it at any time. And I'll come back to it again because that's a really important part of the trust fabric that we work in. As with Massachusetts, we are also now standing up a secure messaging structure and beginning to roll that out with use cases, particularly, again, in the behavioral health community. One of the key objectives over this last year, we went under contract to SAMHSA to demonstrate potential impact of beginning to have those two communities, the general medical community and the behavioral health community, have a more direct link with each other for communication. So part of that is providing access into the general medical information for the behavioral health community, but also introducing an electronic connection, secure messaging connection between the behavioral health community and the general medical community using the direct standard. That's been a really interesting project, and we're very hopeful that this next year, since it was extended yet another year by SAMHSA, we'll start to be able to have some measurable demonstrated impact as a result of a tighter relationship between those two communities and coordinating care. I'm not going to spend much time on the history, only to say this takes a long time. We started this effort really in 2004. I was not there yet, so I take no credit for what was accomplished. But quite frankly, during the period of time, that trust framework, the design and build out of that relationship between 5 stakeholder groups, so really it's the consumer, the provider, the payer, business, and state government, was really at the foundation of allowing some very important things to happen. Probably this is where Maine and Massachusetts differ. First off, size matters. We're smaller. It's easier to work, quite frankly, collaboratively. Secondly, in 2005, the provider communities came together and signed off on a memorandum of understanding that they would do 2 things to make this exchange work. Number one, they would commingle their data into a single database. Interesting. Perhaps more importantly, though, that they agreed to stop competing on patient data. And that's a really fundamental part of a trust framework. We also worked very hard with the consumers during that time. We had a standing consumer structure, which has now turned into actually a standing board, standing committee to my board, who evaluates policy and brings forward recommendations for how to manage, and particularly around privacy and security, but also, quite frankly, just general operating procedures within the exchange. They directly play into review and sign off on the policies of the exchange and the subsequent auditing of the exchange. So basically, we went through a couple of years where yours truly was out raising money. I did a lot of that. And basically, in 2008, we began a demonstration phase, which actually introduced, as John said, a portal view, which is not as desirable as pushing data, but quite frankly, it's where we started. And about half the hospital activity in the state was covered under that. We completed the demonstration phase, went back and looked at our technology, totally ripped out the exchange as we built it, put a brand new exchange in place, and started actual operation as a statewide entity in 2011, January of 2011. Currently, statistics, we have just about, this has gone up a little bit more, we have just about 80% of the state residents have some kind of data in the exchange. Now that could be as simple as a single lab test, or it could be as significant as a number of encounters across a number of organizations. At this point, we have about 1% opting out, and I think this is a testament to what probably still needs to be done more of, and that is we have a state statute that requires all of our participating providers to provide education to patients about their participation in the exchange and what the risks and benefits are, and also what the actions are that the patient can take. This is a very complicated subject. Try explaining at a 6th grade level what health information exchange means. Not easy. And so one of the challenges we have is producing content that consumers can understand at multiple levels of reading and aptitude. And again, it is a very challenging concept to work with. So right now, we are increasing that effort as we enter into the opt-in strategy, because now we're really going to be confusing in terms of what the strategies are. I think that probably if this was as clear as it could be, that opt-out percentage would probably be 1 or 2% higher. But it's something we continue to work on. It's something we have a commitment with the state to work on. And through the state programs like Medicaid, they also engage in trying to educate those members about what we're at. We have, I think, a wonderful story starting to happen here, and that is the incidence of event where a person walks into a facility and there's already data in the system from somewhere else. So right now, a community like Bangor, Maine, which has been now very heavily invested in terms of connection, was part of the Bangor Beacon community strategy. So we have, 80% of the community is connected, and they're seeing that patient as a single entity across the community. Those facilities are seeing as much as 80 to 85% crossover, meaning when a patient comes into their facility, 80 to 85% of the time there's information from somewhere else on that person that they can readily access and bring into their record. So that's really proven to be, it's interesting. It sort of speaks to the question of brand loyalty, of which there is not much, and allows us to encourage, as we head into the accountable care and value-based purchasing strategies, the role of the exchange in helping to manage for both data for treatment, but also, quite frankly, data for reporting and management in ACO concepts. That importance of that community view becomes that much more visible, and it, quite frankly, has now been part of a whole new effort to start to build out that reporting structure. At this point in time, we are now actually over 320 ambulatory practices that are connected, and right now we have 37 of 38 acute and psychiatric hospitals under contract. The last one we will get in another couple of months. And of those, 30 are connected and actually doing bi-directional exchange, and another 5 have view and download access to the exchange. Interesting little project right now. We are working on becoming middleware. We're working with one of our projects in Bangor to actually have them call for a record, and we will push the record to them, and that record will appear in a reconciliation page in their local medical record. They will decide what they want to keep and what they don't want to keep. And so we'll begin to see if we can move into that middleware level going forward. A fairly rich data set, and it has continued to expand over the last 3 years as we have engaged in projects like the Bangor Beacon. The demand for data, for example, that we would not have started with, things like secondary diagnosis, because they needed to do measurement we started to add secondary diagnosis. That is proving to be actually a wonderful decision because now it's helping us work with some others to expand out the value proposition. We're, as I said, central data repository model. A couple things I think that we need to talk about, and maybe we'll get a chance to with the Q&A section. This type of a project begins to introduce some significant additional expectations and requirements, I would say, around auditing. And I mean that both in terms of the physical auditing of structure and policy, but also, quite frankly, in the auditing of use of data. So in our state right now, our exchange has committed to and follows through on a couple of key points of auditing. 2 times a year, an external party does a penetration test on us. We don't know when they're going to do it. We don't know what they're going to attack. And that is, to me, wonderful news when I get reports back that tell me I've got holes, because that's the kind of thing that you got to go fix. So that kind of information needs to come before a board with both a high-level description, not the detail of what was found, and a plan of action that's then followed through in accountability both to the board and to the citizens. Second thing, what we're starting to see increasingly is other types of audit starting to be a necessity. So, for example, we're now working with an ACO, managing information out to them, and lo and behold, we now have to be FSMA compliant. We have to actually have completed a FSMA audit, which we have done, but it's a whole level of expectation that we would not have thought of a year and a half or 2 ago, but now because we're working with Medicare data, we have to, in fact, comply with that. I think, interestingly so, too, we're starting to see the demand that other types of reviews, such as a HIPAA review and CABA, and also in the last little bit, starting to demand for those folks who serve us in doing the processing that they can demonstrate a Type 2 SSAE 16 as part of a continued relationship. All of those things are starting to come together to make this framework as reliable and as safe as it needs to be. I think probably one of the most significant auditing commitments, though, is a commitment to provide an audit to any individual consumer who wants to see who's touching their records. So basically, a consumer can send us a request. We will go ahead and generate an audit. If there's been activity, we show not only who touched them, what they actually looked at. And that's just basically part of that trust framework again. Also, it's a very strange but wonderful thing that's come out of this. We have a community now of security officers at all the participating organizations who have access to and routinely use the audit structures within the exchange. So it's not a mystery to them. They can go in and see actually by patient and or user who's touching an individual, which is an important extension of their role in supporting those folks who may come to them with concerns. So we talked about trust framework. I think John and I are now going to come up on stage and try to do our best in beginning to answer some questions. And Eric's going to sort of guide us through some ideas and concerns. So thank you.
Hello, everybody. My name is Erin McCann. I'm the Associate Editor for Healthcare IT News, and I will be following up with John and Dev for a Q&A. So before we get into questions, first, thank you to both of you for agreeing to be part of the grand finale of the forum. So first off, in terms of creating a fabric of trust, what's the best approach to get everyone involved in a health information exchange to trust each other? You know, for example, a lot of hospitals are competing with each other. How do you get them to change their attitudes over that?
So I'll answer that in 2 ways. So imagine the following conversation. Gary Gottlieb is the CEO of Partners Healthcare, an $8 billion company. And do you know that 15% of the radiology and lab testing done in the Commonwealth of Massachusetts is redundant and unnecessary? So Gary, we're building this health and care information exchange. You know, it's going to be capital intensive. It's going to require a lot of your staff, probably about $1 million investment for all of Partners Healthcare. And when we're done, we're going to reduce your income 15%. Doesn't play very well. But healthcare reform has changed the landscape. So what happened in a fee-for-service world, when you go to the Brigham and get an MRI, then go across Longwood Avenue and get another MRI, both hospitals get paid. Everyone's happy. Patients over-radiated, but the hospitals are happy. In a world of healthcare reform, it is no longer going to be reimbursed. In fact, it becomes a cost in a global capitated contract. So in fact, we would rather you don't have a redundant MRI. We'd rather have no MRI. We'll want the right care, not too little nor too much, to keep the patient well. So Aaron, what happened was, as we saw the ACA pass, hospitals started saying, oh my God, unless we engage in cooperative competition or cooperation, none of us will survive in a global capitated world. It motivated everybody to join the governance of the HIE. We had over 100 participants across policy and technology committees that ended up writing all of the framework that the technology then was built around.
It's interesting, we got there at a different time because this process was going on in 2005, but with much the same outcome. In this case, in Maine, it's frequently the case that the hospital is the largest employer, not a surprise in some of these communities, and therefore seen as an economic engine. But they also, quite frankly, are increasingly seen as very expensive balloons. And I think part of the decision-making in 2005 that drove these folks to agree to this concept of stopping competing on patient data was the fact that they were fearing that the next step would be increased pricing reduction, payment reduction by the state, particularly for Medicaid, because they were viewed as too expensive. And so in part, the concepts of starting to share data so that they would not, in fact, continue to run up expense was well aligned because they're losing money on the Medicaid patients anyway. And so that's part of what drove it. It was a political fear that they were the largest play in town and that the state was starting to come to a point where they couldn't afford hospitals anymore. And so that sort of thing drove them into each other's arms. And I think what came along with that, too, was an understanding with business and engagement of business in the discussion. So you ask, how do you do it? You bring a bunch of stakeholders together, you understand their separate and perhaps contradictory objectives, and then you find the places where they agree, and you start to build a consensus around that for why this is going to be a good thing, even though you may not agree on all aspects of it. And then you just keep working on nurturing that, building it up. And eventually, you get to a point where there's enough success that even though any one stakeholder may not have gotten everything they want, they've got a little bit of something. Then you just keep working on it.
Now, moving away from providers and hospitals, how do you actually assure the patient that their health information is going to be protected and confidential?
So as you said, I mean, there's this immense education process. In 2005, so right around the time you were dealing with this, we did an experiment. Blue Cross paid $50 million to get EHRs installed in 3 communities in Massachusetts, Brockton, Newburyport, and North Adams. And we wanted to share the data. But we are an opt-in state. That is the nature of our Chapter 305 law. So we took 20,000 adults in North Adams, and we created this wonderful bit of a health information exchange educational material written at the 6th grade level. It is possible. They basically said this: we're going to share your data with your consent among providers who are going to be engaged in your care. If you do it, we're going to pretty much help with safe, quality, efficient care, and if you don't, you'll probably die. It wasn't that blunt. But what we ended up with is sort of similar numbers to what you did, which was about 98% opt-in, where in a brochure that explained the risks, data spillage, inappropriate viewing or access to your record, and the benefits, that overall, 98% of the adults said, you know, I actually think as long as it's my decision and it's the doctors in my community and it's for my direct care, it's okay. And in our modern 2010, 2011 healthcare information exchange effort, we had a patient and consumer engagement committee that worked on education and how do we get the artifacts into the hands of multiple groups so that the patients would understand what we were doing and why.
And it's interesting, when Massachusetts came out with that document, we were just starting the internal debate across a fairly interesting mix of consumer advocates and consumer representatives. And that document, that brochure, became part of our initial discussion of how would you do it? Is it an opt-in? Is it an opt-out? And it actually served as a very nice foundation for what then came as an educational process. Challenge there, though, still continues to be the degree of lack of understanding, and God, I can't guess why, of how complicated this is in terms of explaining to a mere mortal what it is we do for a living every day. And the challenge really is to have people truly take away from that a legitimate sense of risk and opportunity that they can play back against their own internal sense of risk and opportunity and make an informed decision against. And I would argue that as much as we've tried and we continue to try to do better, there is still a gap there, that this is just plain complicated. And it doesn't rest easily in terms of most people's perceptions of what goes on. Either they're surprised to hear that John can't send me data already, that's a big surprise, or they're surprised to hear that we're even thinking about doing that. And so getting those concepts of risk and value in place really are hard, simply because the context where you're starting from with the consumer is so broad, and the lack of true understanding of the structures is so narrow that you really are starting with a very complicated challenge.
One other interesting service, Leon was here, and he actually performs a pretty valuable public service in the following regard. Yeah. Why is it that we all trust the stock market? Well, it's because we believe, I think, that the SEC as a watchdog keeps, to the extent that there's integrity and, both data and practice and policy, keeps people pretty honest. So in effect, Leon's job is to do the same thing for all the patients of America, that if you find those with lost mobile devices or sloppy practices and policies getting charged and then told to remediate, it's going to build this trust in the fabric that Leon is watching out for us.
Yeah, that's a good point.
Now, you talked a little bit about communicating with the patients, so on to, I guess, policy making. Can you discuss how security policy is made for your HIE?
Sure. You want to do that?
Yeah, sure. And so again, it's consensus, bottom up. We bring together folks who are employers, payers, patients, providers, legal people, academics, and work groups. Spend endless hours looking at the pros and the cons of various policies, bubble up a series of principles. Those go through a committee of about 100 folks, and ultimately up to EOHHS, the Health and Human Services folks, through the governance of our state is something called the HIT Council, was actually established by regulation, and then the members of the HIT Council say, yep. So nothing like bottom-up, consensus-driven, and then government-enforced regulation.
And I would agree. Basically, we're obviously on a much smaller scale. Maine's about a fifth the size of Massachusetts, so we have about a fifth less structure. But the fact is that starting from that foundation, interestingly, working through the various stakeholders with versions of those policies is really the foundation for moving that through to a point where you actually have a working framework and you have an understanding. One of the most exciting and perhaps challenging times was actually bringing together those security officers for the first time from all the participating organizations and getting them to trust each other. It was really fascinating. We spent about a year with this very interesting dance of these guys and ladies, only two ladies, so guys and ladies, moving around each other, trying to figure out, what's your sanction policy versus my sanction policy, and do I trust your sanction policy? And in the middle of it was the Health Information Exchange's proposed policies on practice. We got two things out of it. We got a number of greatly strengthened sanction policies at the institution level because they saw what others were doing. They said, oh my God, we're not doing enough. And we got an understanding of clearly how the relationship between the exchange and their role and their responsibilities was going to work. And that's been a process which, as John says, it keeps going. It doesn't ever stop. You have to keep reiterating. Every time you add something, change something, someone else comes to the picture, you got to go back and address it again. But I don't think there's any other way to do that than to do it as an organic process.
Now, moving on to the auditing process, the most exciting part. How do your organizations authenticate system users and audits, logging in and logging in?
You talk about that again.
Sure. So at organizational level and an HIE level, I'll tell you about that. So at Beth Israel Deaconess, we have username and password. It has the usual strength. It's the 8-character mixed case alphanumeric, expiration, auto timeouts, all the sort of usual things you'd want, encryption of client devices. And we are in the process of implementing an adaptive authentication service so that if suddenly you show up in France and you've never been in France before, and that sounds pretty weird, that you're not trusted any longer and that you have to do a second factor authentication. Favorite one at the moment is we send a PIN code to your known registered cell phone and you use that in addition to your username and password. At the HIE level, the credentials that have been used in the system of your local institution to access the HIE are forwarded to the HIE. So that is, audit logs describe who accessed what, from where, and when.
And we have a similar strategy where once you have become a participant, you're actually involved in a mutually assured destruction pact, because you're taking on the responsibility for your people to behave well, and the guy across town is assuming that his people are going to behave well, and if something goes down, you're both going down together, in essence, in terms of that. But I think what's really interesting, we have basically a core two-factor authentication in that for those institutions that connect to us directly through a more traditional structure like a VPN, the fact that they have actually entered their own EMR and have authenticated against it, and then are coming from a single trusted port into the exchange, allows us to basically do username and password as a factor. If they're coming in from a practice that does not have that kind of capability, then we do use a certificate-based strategy where we provide certificates in local into practice that is actually, John's quite right, very complicated because they're person-specific, and it's a real pain in the tail to manage. But it basically allows us the confidence that those practices will, in fact, be authenticating against the user who says they are who they are. The other thing I think that's really interesting, and so far in our experience, is that dampening effect in the education of those in the practice when they learn that we, in fact, are actively encouraging consumers to seek audit. That has a wonderful dampening effect on some behaviors. And then finally, I think the thing that I find most interesting and challenging in this whole concept is because we do a role-based relationship, meaning that not everybody gets to see everything. So we have right now six roles that have different levels of access and exposure to different types of content. The responsibility rests on the provider organization who authorizes a person to be able to have access to also subscribe to the correct role for that person. We do not take risk for that. They take the risk for misassigning an individual to a role that provides more data than they should in fact be able to see. And that's a key thing. Again, sharing that risk in a balanced way across those institutions is a very powerful thing.
And, you know, in regards to a health information exchange, what's required by HIPAA, and would you ever recommend going beyond those HIPAA requirements?
Well, so remember, we rarely have high tech at the moment that's in many ways is much more specific than HIPAA. So we look for HIPAA, which says notice of privacy practices, unique username and password, audit, but high tech, which has all the breach reporting requirements and then the various meaningful use layered on top of that, has certain aspects of encryption that are required. So we certainly watch all the federal regulations. But you know what's most important? It's not HIPAA or high tech. It's actually the Boston Globe. Yeah. Or the New York Times. Use whatever media is appropriate. The Bangor Times,
yeah,
whatever.
Bangor Daily.
Because if you show up as having had a breach, and Leon said it well, I mean, breaches happen, but if it was because you were sloppy, you will lose the trust of your patients. You really only have one chance to get security right, because once you've lost trust, it's very hard to regain.
Absolutely. And for us, because we feel that we are going to a place and in a place that is foreign and unknown to the consumer, in the sense that people do have an aversion to aggregation. We understand that. We feel that we have to operate at a level that's higher than we would expect, perhaps even with HIPAA, in terms of some of our strategies. I think some of the things that we've tried to do, for example, is within the actual physical architecture of the exchange, we've taken advantage of the opportunity to split the two data sets apart. So basically the person identification data set lives separately from the clinical data set and is knit back together again through web service call. And secondly, we've taken advantage of basically encrypting at rest using some of the newer technologies in SQL and also in Oracle, so that now you've got two levels of challenge for somebody who tries to hack the structure, really three. One, they've got to get through the encryption concepts. Two, they've got to figure out the web service calls to knit the relationships back together again. And I think those are important concepts. It isn't perfect. Someone still could probably break it eventually if they tried hard enough. But I think it's a reasonable standard of practice. It is a standard of practice that is higher than we think most of our own organizations in Maine are practicing at right now. But that's an obligation because of what we are doing and how, if the perception, if not the reality of exposure for the consumer in particular. John's absolutely right. At the end of the day, if I screw up, I lose it all. I mean, that's just a fact. The trust will just go, and that will close the exchange down faster than anything.
Moving on to the subject of standards, could you describe your privacy architecture?
Sure, I just started.
Well, sure. So, I mean, when we think of standards, right, there are three kinds of standards used in healthcare. There's transport standards, content standards, and vocabulary standards. So the transport standards we use are the direct protocols. You'll find it if you just Google the direct project, which is either a SMTP, SMIME approach that uses certificates and sender and receiver to ensure payloads are encrypted, or we use XDR, which is a SOAP implementation also enforced by certificates. And then, of course, we maintain audit trails. The audit trails are not so much a standard. I mean, ASTM has a standard of the data elements that you should include in an audit trail, and we follow that ASTM standard. On the encryption side, we always point back to FIPS and FISMA, these federal information privacy security policies. And so meaningful use hasn't specifically said, you must use this AES flavor. You must use triple DES. No, let's go whatever is the appropriate, FIPS 140-2, what is the nature of the encryption that's considered safe today? That's what we would use.
Yeah, I think it's essentially the same thing true. I mentioned the encryption at rest. We are using the transparent data encryption as a standard now for our practices. It's not perfect. In fact, quite frankly, I think our biggest risk, John has this problem too, is the authorized user. At the end of the day, that's the greatest challenge in terms of exposure to breaches. The person who actually has the authority to be there, has the reason to be there, and does stupid things. And that continues to be a challenge which even audit can't drive out totally. So for us, basically, a lot of the standards we've talked about right now we're a fairly traditional structure in that we are using VPN or HTTP with some form of wrapper around the content moving between us and the provider site. But I think right now what we're starting to see is that we are being pushed into some true factor authentication requirements for anyone who is not physically connected by a dedicated circuit. It just has to be.
Now, anyone from the audience have any questions for Dev or John?
The ultimate goal for health information exchange is, allow any provider at the country, in the nationwide, and they can exchange the patient information in a secure and authorized way, right? So now we see the successful implementation from Massachusetts and also from Maine. And through the discussion of this panel, I noticed that, at least from the kind of, the infrastructure and the technology perspective, there are some kind of the different approaches. We have to remember, eventually, all these kind of regional network has to be integrated, right? So I think, that's part of the very high level kind of, the vision at the kind of nation level, right? So how do you see that kind of a concern, in the future when the main network, integrate with the Massachusetts or with any other kind of a regional network? And how do you address that kind of a concern at this point in time?
So this is, of course, the ultimate challenge. Yes, there is a nationwide health information network architecture, a new federal project that is the Health E-Exchange. It all depends on certificates, and those certificates are going to have to be trusted so that your fabric and my fabric trust each other. And what are the three ways we could do that? So there's the federal bridge effort, and maybe that will evolve. There's a directtrust.org effort, which is looking at taking trust domains and affiliating them, and that may go somewhere. And there's the NSTIC effort, so the National Strategy for Trusted Identity in Cyberspace. I think the interesting question for us all is, of those three efforts, which one is going to win? It's Betamax versus VHS. And I think at the moment, at the Standards Committee at the national level, we're looking at the NSTIC work and thinking, we should probably align our efforts with the National Strategy for Trusted Identity in Cyberspace.
I defer to John on this simply because he is leading that charge, right, in terms of the standards. And for us, as a working exchange, our challenge is to close no doors. As we put the physical infrastructure in place, the challenge is to make sure that we're constantly watching what John's doing in DC, trying to drive those standards to some maturity and make sure we don't shut down options on how to actually be at that standard if, in fact, one of those three proves to be the ultimate winner.
Another question I want to have is, really about the kind of the data management or content management. Because, if you think about the internet, use the internet as an analogy to compares to the health information exchange, right? So I mean, on the internet, typical thing is, when you have the free flow of the information, a lot of cases, you also run into a situation that, you don't have the capability to track which one is the authoritative version of the original data.
Right.
In the healthcare information exchange, do you have the similar concern, or what is the kind of mechanism has been there, to manage the authenticity of the information, to track the original owner of the information?
This is a really troubling challenge in that what comes into the data, into the exchange, always has the originating metadata associated with it. So at least in that first iteration of exchange, we know source, we know who performed it, we know who ordered it, we know when it was done, et cetera, et cetera. The problem is once you move parts or all of that back out to the second or third iteration, does that metadata stay with it? And I'm not so sure I can answer the question once it gets 2 or 3 leaps away from me. It should stay with it, but I don't know that I know that for sure.
Right, the answer is metadata. So what you'll see, we did it a little bit in 2012 with some of the standards for meaningful use stage 2, but as we work on meaningful use stage 3, I just spent the earlier part of the day working on the agenda for the 2013 HIT Standards and Policy Committee agenda, and the first thing on our agenda is persistent metadata that will follow the data from source to destination so you know the authoritative source.
Okay.
So coming soon.
Yeah. Can't come soon.
One more question?
Did you, in your development of the HIE, look at ways that data leaks outside of the HIE? The reason I'm asking the question is, John, you gave a very good example, and coming from a community mental health center that's trying to pursue meaningful use, we have an electronic EHR. E-prescribing system, I'm sorry, wrong word, e-prescribing system, and one of the benefits that they gave to us was we would see all of the third-party, we would see all of the prescriptions that were paid for by third-party payers. So you made me realize that when you said you didn't want to see the Betty Ford or the HIV stuff, my doctor could see that, even though through the Health Information Exchange, he didn't have, or she didn't have, the authority to do that. So did you look at any of those issues?
So I'll answer this in a peculiar way. You must not be from Massachusetts. Because it turns out in Massachusetts, we actually have a regulation that prohibits payers from sharing HIV, mental health, and substance abuse-related medications through PBMs and networks like SureScripts. So, the example, let's say I'm on AZT for HIV, and I'm on methadone for my substance abuse, and I'm on Prozac. If you were to go query the Pharmacy Benefit Management database in Massachusetts, it will tell you I'm taking nothing at all. Even with my consent, they can't release it. So we cover that with policy. But your comments are very well taken, which is it is, alas, extraordinarily hard to prevent the misuse of data by an authorized user. We can have policies against you will not take data from the Health Information Exchange and put it on a thumb drive. But how do you prevent that user from doing so? It's a real challenge.
Yeah, it's interesting. Maine does not have the same laws as Massachusetts, and it has been a policy debate which played out in a very odd way when we started to bring on the prescription information for our Medicaid program. The Attorney General decided that that data in and of itself constituted a diagnosis. And that's our standard of practice in Maine. You can't expose those diagnoses for mental health, HIV, and substance abuse treatment. And so we got into this rather delicate dance between the clinician's perspective that you're putting the highest risk population at further risk by not sharing that data, and the very question of, well, a smart clinician can infer a diagnosis. They may be wrong, by the way, but they can infer a diagnosis from that medication profile. Long story short, we had a settlement in essence where last year our Commissioner of Health and Human Services decided that the risk outweighed the discussion of filtering, and she rescinded the order to filter, and now that data is presented as part of the prescription profile. Go figure. I mean, I think there's an argument on both sides there, the privacy and confidentiality side versus the patient safety side. And at least in this case, within the context of Maine law, that patient safety side has won out for now.
And you've said it very well. I mean, like everything you guys do for a living, you assess the risks and then make a decision at a policy level what risks you accept, because they are actually probably more beneficial to accept them and move forward.
All right. Well, thank you both so very much, and thank you to all of you out there. Appreciate it.
Good to see you.